Okay, so this was the performance on the pre-assessment quiz. Oh, wow. Now, it is actually a pretty nice bell curve. I could go with that. But I sure would like to see it shift way to the right. Because basically here we're looking at, this is a group that scored 50% or below. Now, the truth is, it asked a whole bunch of questions based on reading from and I know it was a summer break, and, it all goes away. I would actually expect, and actually last semester, the group that was in spring, who had just finished, they did a little bit better. The overall average, the score was 62%. And in the previous class, it was 67. And statistically, that's really not significant. It says that you guys forget about half of what you learned before you get here. And I have no control over that, and it's not how Professor Bright's teaching it. It's just, that's kind of the nature of the beast. We learn a lot of stuff. And the expectation is you will know a lot of stuff. And that's the hard thing about being a nurse. If anybody could be a nurse, it'd be easy, wouldn't it? I think. Okay. Questions on what we've not covered so far? Questions on what we have covered so far? Come on, give me. So today, what else do I? Oh, there was I got to put my glasses back on. So one of the things I posted, because with the case studies that will be coming up, I'm going to be using Turnitin. Now, have all of you used Turnitin before? So you're probably more literate about it than I am. But in the event you need stuff, there is, actually I did put up the, where is it? Oh, come on. So there is, the course ID and password are up there. And what I'm looking for is that you're not copying from each other. And then you're not, plagiarizing some book or journal article somewhere. That doesn't mean you can't quote stuff as long as you attribute it. It's all proper APA format. So if somebody said it so beautifully that you want to, quote that statement and put it at the bottom, that was by, Joe Blow. It was good, and it was in the Journal of, Nursing Review. Go for it. Okay. I think I'm looking for 3. I will accept your text as one of your peer-reviewed references, but I would like to see 2 other peer-reviewed references. So that means it's not People magazine writing an article about insulin. It needs to be a peer-reviewed research article. There's lots of them out there. They're easy to find. Of course, you guys don't know what I'm going to be asking you yet, but that's coming soon. Oh, and the other thing I added to yesterday, so there's group presentations. In theory, there was going to be a group presentation today. Of course, I didn't have you sign up last week, so it really wasn't appropriate to say come in and start doing group presentations. But these are actually Google Docs. If you go into the document, you will see that there is 6 potential dates for groups of up to 5. So you guys get together, figure out which group you want to be, what presentation you want to do. And it would be better if you guys signed up for the morning class because you're not in the afternoon. And just pick a topic and start working on it. So the first one is actually due 2 weeks from today. Because next week is our first test. You want to know about the test at all? What do you want to know? What are the questions? Okay, we're going to be talking about, the things we're talking about today. We're going to be talking about transfusions and, central line. The questions on the test will kind of cover, like, safe use of central lines, TPN, some of the stuff we actually covered in pharm. So you have the advantage of, we're talking about the same things at the same time. Hopefully some of it sticks. Sometimes it does, sometimes it doesn't. There might even be a med math question in there. I don't remember. I have to go look and see what test questions I'm doing. But these are actually reviewed questions out of the book, more or less, or from your reading topics and from here. You will also note at the top of my class notes, it'll say, when you're done with this section, you should know how to answer these questions. You should know how to answer those questions because they're probably going to show up in the midterm. There's your study guide right there. Right.
How many questions do you have to bring Scantron?
You do have to bring your Scantron, bring the 100 question size, because the other ones, the ones that are the half sheet, our Scantron machine won't read those and it'll be a really bad day. So you need the full 8.5 by 11 sheet. And yeah, they changed policy last year. We used to supply them. We don't anymore. Yeah, let me finish. I got you. So you asked how many questions? 50 questions and one case study question. It's a little essay question. It'll be very succinct. But basically, you get 50 points for the Scantron and then 5 points for the essay. And I'll be asking things like, ultimately the question is going to be, what is your nursing priority? What are you looking for with this patient that might go wrong? And I can tell you right up front, if you tell me pain, safety, falls, call the doctor, you are in trouble, because that's not going to be an answer. Unless with call the doctor, I'm going to call the doctor and tell them this, and this, so that they will order that. But you got to think, if you're going to call the doctor, first thing the doctor is going to say is, so yeah, what's their vitals? What's the problem? Why are you calling me? If you can't answer the question why you're calling, don't call the doctor. It also won't be right on the NCLEX if you say, call the provider. I can guarantee you that will not be the right answer. You had a question. Oh, it's not letting you edit? I'm still learning about Google Docs. I actually hate Google, even though I was a software engineer. Let me do a little homework and figure out how you can get in there to actually edit it. Because I thought I had shared it for editing, but apparently I didn't. And I'm glad you're looking, because now I know. So I'll fix that tomorrow. I promise. At least I hope I will. And if I don't, somebody will email me and say, you still didn't fix it. Other questions about the exam next week? No? 55. So there'll be 50 questions worth 1 point each and one 5-point question, which will be the handwrite it. Please make it almost legible. There'll be space on the paper to write, yeah. On the first 2 lectures and reading. It could be on there, yes. You are responsible for the reading. The test will probably focus on what I've covered in the lecture, but I feel that I'm completely free to ask questions about anything I told you to read about, especially if they're fundamental things like fluid and electrolytes. And will we be tested at all on protocols? You should kind of know what they're about, because the protocols tend to be consistent across facilities. Like, there'll be protocols around, sterile procedure for a central line change. You kind of should know whether it's a sterile procedure or, is it just a clean procedure? Aseptic? What's the difference between aseptic and sterile? That's a homework assignment for you guys. Go look up the difference between the two. You should know that because it's important. Somebody, you had a question, right? Did I see a hand over here? No? Any other questions? All right. That clock's working. Over in Guzman, none of the clocks are working, which is really distracting. So it's like I have no clue about what time it is, which is really bad. Okay, practice quiz, morning class group. Yeah, come on, where's my lecture? Let's talk about transfusion therapy. What is a transfusion? Anybody know? It can be blood, yes. Oh, I meant to open this while you guys were taking the quiz. My apologies. It's typically blood products. There's a whole range of blood products. starting with whole blood, which we basically never give, except in extremely rare situations. What you will typically see being given as blood will be PRBCs. Have you heard that term or that acronym? Anybody know what it stands for? PRBCs. No, we're not premature with blood. Packed red blood cells.
That's whole blood?
No, whole blood is not packed. So when they're packed, what they've done is they've centrifuged it and drawn off some of the fluid. The goal here is to not fluid overload your patient. So a unit of blood has less fluid than a liter of blood, so to speak. But it may have all the red cells. And if this PowerPoint ever opens up, if it doesn't, I will. Oh, it looks like it's getting close there. I'm sorry, I fully intended to do this, along with a lot of other things I fully intended to do. Okay. From the beginning. I'll look at my notes, too. Hopefully it won't start talking to me. All right. 32,000 units per day. That's a lot of blood. This is not right here. Why am I looking at the wrong page here? Okay. Your instructor has had a senior moment. There we go. This will work a lot better. I have my folder upside down. Years ago, I was 19. I was working in a psychiatric unit in Berkeley, going to school. And our nursing supervisor was this really sweet, white-haired lady who probably had to be in her late 70s. And she came down to our unit one day, and the nurse and I are sitting there talking. The unit was basically a halfway house type of psych unit, so the patients had day passes and stuff. So we're just hanging out. The phone rings, and the supervisor picks up the phone, but picks it up upside down, puts it to her ear. Hello? Hello? Huh. Hangs it back up, and the nurse and I are like looking at each other, like, oh God, it's going to be one of those days. Yeah, she was cute. She really. It was okay. I was in a psych unit. It didn't really matter, right? I may have to edit that. I don't know. We'll see. Okay. Let's talk about blood transfusions. That would be much better. Blood transfusions, they actually do save lives. It's a big deal. You can, what are the two main complications we have to be concerned about? Well, blood reactions and transmission of bloodborne diseases. I mean, if you give the wrong kind of blood to somebody, you can kill them. If you're not lucky. If you're lucky, you can, intervene soon enough. The main bloodborne diseases are things like Hep C, HIV. They're viral. Of course, it could be syphilis. Not a good day. Before the 1980s, they didn't screen for Hep C or, of course, for HIV. They didn't even know it existed, which is why people ended up with those maladies. Yeah. Because Hep C, yeah. Hep C is one of those. You see the ads that are showing up on TV now for drugs for Hep C. You know why those were developed? Other than the fact that they wanted to help people that have Hep C. So what does it take for a drug company to develop something other than need? What do they want to make? Money. So if there's only 10 patients that have that malady, do you think they're going to spend $500 million developing a drug? So in my generation, the late 60s, there was a lot of experimentation, particularly with, IV drugs. Didn't lead to a whole lot of addictions. It was just a lot of people were trying heroin and stuff. And we basically inoculated a population with a lot of Hep C. Now, Hep C takes maybe decades to express itself. We have an epidemic of Hep C now, basically. So now there's enough population for the drug companies to say, hey, we should develop something. We could sell that. Anyway, I get cynical at times. So blood's always in short supply, and especially O negative, because is that the universal donor? Did you guys do the reading? Anybody remember? Yeah. Oh, okay. Well, that's okay. We'll talk. We'll know for sure in a minute here. We'll continue on. And it was the GAN Act, that actually initiated this idea that we're going to really that we're going to screen blood for all these bloodborne diseases. So, you guys have met Dorothy. She's over in the sim lab, right? Lucky lady. She's as old as I am. She had a total knee. And her HGB, her hemoglobin, is down to 9 deciliters. And her hematocrit, 25%. Is that normal? What's normal for an H&H-ish for women? It's different for men and women. Men tend to have more of each for various and sundry reasons, mostly because we don't have periods normally. So what's the normal range? Somebody, look it up if you have to, yeah. Oh, both, or each. Okay. Yeah, okay. So is she in that range? No, she's pretty anemic. Why do you think she lost so much blood? Yeah, but it has to do with the kind of surgery. Hip surgery and knee surgeries are pretty invasive, and they actually do have a lot of bleeding. So it's not unusual for people to lose blood in that surgery. Have you seen in the reports? Have you seen a line? Particularly in the electronic records, you'll see EBL. Has anybody seen that acronym EBL from the surgical report? Not yet. You will. Anybody want to guess as to what it means? Since we're talking about blood, estimated blood loss. The surgeons tell you, oh, they lost 50 mLs, 10 mLs. I've seen a liter on a bad day or more. Or they've had, they lost 2 liters and we were replacing blood and blood products like crazy because they were bleeding like crazy. But so why do you think she's dizzy, hypotensive, and tachycardic? What is she missing in terms of being, you're right, she's a little hypovolemic, probably. Why is she tachycardic? Yeah, her oxygen carrying capacity has dropped. Years ago, I had a retroperitoneal bleed. My hematocrit dropped by 50%. Now, it was kind of confusing to them because my hematocrit, I tend to be, I hang out just under polycythemia. So I'm like 55. So when I dropped, I still was kind of in the low normal range. But as far as my body was concerned, it was not good. And I swear, every nurse came, this is when I was working in the intensive care, so I ended up in the hospital I worked in, which is a little weird. But, I felt safe there. I swear, every nurse came in and asked me, why are you so tacky? And I'm thinking, where did you go to school? What did you not learn about basic physiology? If I have less blood, it has to go around faster because how many times around does it take to use up all the oxygen in your blood? If you were suffocating or holding your breath, how many how many times through the system? How much of your oxygen is used on each pass? Let's put it that way. Anybody remember that number? Where did you guys take your patho? Never mind. Hopefully it wasn't here. So, okay. 25% more or less for each pass. How long does that take for it to make one complete pass? About a minute. So at 4 minutes, you've made 4 passes, you've used 100% of your oxygen, and that's why you start getting hypoxic brain injuries after 4 or 5 minutes of not breathing and, with no oxygen, that's kind of the golden number for ACLS and for BLS, all those good things. Remember those, they're handy. I don't know if they'll be on the NCLEX, but you should know them just because it's good to know. Where was I? Tachycardia. Okay. So, you call up the doctor about Dorothy, and the doctor orders an autologous blood transfusion. What's autologous? You guys didn't do the reading. Yeah, Nick? Right. She's getting her own blood back. She, 3 months before the surgery, she went in and donated a couple times. And they stored, well, not 3 months, because it'd be kind of old blood at that point. But, yes, she donated her own blood for her own use. That way you know that there's really probably unlikely to be any problems with the blood, at least in terms of typing and cross-matching, because it's her blood. And she's not going to give herself any disease she doesn't already have. So let's talk about the ABO compatibility. There's 3 kinds of antigens. A, B, there's no O, by the way, and Rh factor. But O does matter, okay? All of you have some kind of blood, and you all have a type. Last I checked. There's actually like 32 different blood groups that have been identified. There's probably even more than that. But it's those 3 major ones and the Rh factor that matter the most, because they're the ones that have the greatest reaction if you give somebody the wrong type. So our immune system, if I'm type A, I make antibodies against type B. If I'm type B, I make antibodies against A. If I'm AB, probably okay. I can get a transfusion of A or B. Otherwise, A for A, B for B. Now, O doesn't have any surface antigens, which is why you can give it to anybody. And that's why O is in demand, and they're actually fairly rare. And we'll talk about Rh in a minute, but O negative means that they don't have the Rh factor either. So what happens when you give somebody the wrong type? What kind of a response are we going to see? If I introduced a bacteria into your bloodstream, what's your system going to do? So what's the name of that attack? What kind of a response is that? It's immune. And the immune system triggers what kind of reactions? No, I'm not thinking suppression so much. Sorry? Okay, cytokines. Now you get very specific. Well, what do we typically call that reaction with that release? What are the symptoms you see? Like if you've cut yourself and there's all this stuff in there and the body's reacting, what happens at that injury? Does it get red? What's that called? Inflammation. So it's the inflammation. See, I ask these really easy questions. Oh my, they're wrecking their brains looking for the answer, and it's like, oh, inflammation. I know that. So it's the inflammatory response. And we'll talk about this later in another lecture, but when you have a patient who is suffering from sepsis, that's actually a runaway inflammatory response. Because the way the inflammatory response works, it's supposed to be localized and hopefully sort of shuts itself back down. But sometimes things go crazy and the whole body gets involved in it, and it's really bad. Mortality rate for severe sepsis is 40%. And we actually still don't know really how it happens. It's treated empirically. Have you heard that term, to talk about treating something empirically? Do you know what it actually means? What is it talking about? If you read in a doctor's note, I'm treating this empirically and I'm ordering these antibiotics, what are they saying to you? Yeah. Well, they may be testing. So in essence, they're saying, we don't know what it is. We're going to give everything. Empirically means, actually what it really more means is, based on prior history, we know that this approach works. A lot of engineering uses empirical data. We built a bridge. It fell down. We built a better bridge. It fell down. We built a better bridge. It stayed up. Oh, we need to build bridges the way we did the third way. That's empirical evidence. At this point, the engineers actually are using all kinds of physics and formulas behind that. But the original design for bridges was based on empirical evidence. So an empirical treatment for sepsis says, we know if you give them a lot of fluids, give them antibiotics within 90 minutes, and supportive care, they are more likely to survive. But it doesn't mean we actually know what's really going on, why the runaway inflammatory process, why this all actually happened to some people and not others. And that has only something to do with this. So I kind of talked about A's can get A or O, B can get B or O, AB can get AB or O. What can O get? I think they have to get just O. They can't get A or B or AB because they're going to react to all of them. So if you're type O and you start bleeding, hope that there's a lot of people around that week that had O blood donations. Okay, where am I? Slide 4. There was a lot of stuff there on slide 3. You'll find the notes are much longer than what I'm talking about in some ways. They're more specific. And that's why you want to go back and read the lecture notes, particularly before the exam. Because if I have managed to digress and not really cover something in detail, the detail's in those notes. The last spring, on the third midterm, which the class basically bombed, I went back and did an analysis on a question-by-question basis. And then I went looking for where the answers were. And I found, for every question that they all missed, exact phrases out of the notes. Question 34 was found on this slide. So read the notes. It's a really good idea. It really is an effective study guide. When you come back, okay. So let's talk about acute hemolytic reactions, otherwise known as a transfusion reaction. So this is the worst kind of reaction you can get with a blood transfusion. And that's what happens when you give them an incompatible blood type. You give B to A. So you get this massive inflammatory response, and like you say, it is an immune response. Everything attacks those foreign cells. They agglutinate. You remember what agglutinate means? They glue together. So now you have all this chunks floating through the bloodstream. Do chunks go through the kidneys well? Yeah. So what's one of the problems with a severe hemolytic reaction? What organ in particular is going to be damaged? Kidneys. But it impacts any place where you've got really small capillaries, which is like the entire body, all your organs. Because now what you have is, they're not clots, but they do block the blood flow to areas that are, circulated by really fine capillaries. So you will have all kinds of muscle aches, fever, which of course is part of the inflammatory response, hypotension, you have bleeding that you can't control because it impacts the clotting cascade. Yeah, lumbar, pain in the lumbar region because of the kidneys. Chest pain. Why do you think you have chest pain? Do we have capillaries inside the heart? If you load them up with this agglutinated red cells, is blood going to be getting to that heart muscle? Is it going to like that? Nah. Yeah, it hurts. Could you do me a favor? Could you kind of just close the door down a little bit? It's kind of noisy. Thank you. Well, not all the, because this room is pretty stuffy. See, that's the hard part, is getting those things to work. And of course, your urinary systems. That works. It's a tripping hazard, but we'll be okay. We're all bright. We can look. All of us are not too visually impaired. Okay, I have an A negative patient. Can I give him A positive? Not a really good idea. Can I give him O negative? Yeah? Can I give him a B negative? Nope. Certainly not B positive. So this is not the best choice, but it is a safe enough choice. You could, in a pinch, actually give A positive if they've never had an RH positive exposure before. They will have a reaction, but it will be delayed, and it probably won't be as acute. However, if you give them a second unit, you'll start getting into the acute reactions, because that one is a less intense reaction. And of course, if they are female, it's going to have an impact if they have an A positive baby. We'll talk about that too. Someday. No, this afternoon. Okay. So, let's speak about that right now. RH negative mother with an RH positive baby. So the blood mixes during delivery, and actually the evidence is showing that it mixes even a lot more than they ever thought prior to delivery. But mom's going to start making antibodies against that RH. And with the next pregnancy, if there's nothing done to prevent that, or let's say prevent for the moment, next time it's going to be a much more potent reaction and can kill the kid. And that's why, this RH mismatch, I can't talk, mismatch, yeah. I don't think I had a stroke. So you can give ROGAM. Any of you hear of that before? You haven't done oh, you have. Family experience, not to pry. So you've heard about ROGAM?
Yeah.
Cool. Do you know how it works? Well, we haven't taught that in the other class yet, so that's okay. Right. So ROGAM's kind of interesting. It doesn't interfere with your immune response. What it does is basically hide the fact that there's RH positive stuff floating around in the bloodstream. It hides that antigen from the immune system. And therefore, the immune system doesn't know that there's an RH positive kid in the uterus. And therefore, it doesn't build up the additional antibodies for it. So that's given in the 28th week of pregnancy and after the baby is born. And the goal is to keep mom... one of the words you will see is naive. If somebody is naive, used in a medical term, it means they haven't been exposed before. You'll also hear it used in terms like if somebody is getting metoprolol, or particularly Lasix. If they've never had it before and they are naive, what you will get is really profound reactions the first time they get it. You give somebody 10 milligrams of Lasix or furosemide that's never had it before. As the saying goes, they will pee like a racehorse. They will not be happy that you put a urinal next to their bed because it's really probably not going to be quite adequate for them, even for the men. And for the women, it's that much worse because they got the stupid bedpan. So that's actually a time to talk to the doctor. I'm like, don't you think a Foley would be good while they're on the Lasix? Although, are Foleys discouraged in the hospital now? Why? UTIs, yeah. Will Medicare pay for a Foley? Actually, it does, but you have to be able to justify it, and they want them to come out as quickly as possible. I'm not so sure about a Foley-induced urinary tract infection. That might not get paid for. I don't know. I don't think that's under regulations yet, but I wouldn't be surprised. Question? Or are you just... Okay. We can do that. So let's talk about typing, cross-matching, and screening. When does this class end? 45 minutes, okay. You want to take a 5-minute break? Sure, it's getting warm. You want to run downstairs, get a cup of coffee or donut or whatever? So be back before 11, okay? And then we will start talking about typing, cross-matching, and stuff like that. Okay, let's talk about type, screen, and cross-match. So we're back now. I'm sorry. Before, what's allogenic blood? The other was autologous, right? It was transfused to yourself. So what do you think allogenic is? Somebody else's, yeah. Okay. So before we give allogenic blood, you have to screen their blood to make sure that they match. And certainly on these, major groups, they do that. And like I said, the real tests are actually far more detailed than that. So you, the nurse, because the lab does not draw for type and cross match. Nurses draw. And it takes 2 RN signatures on those tubes. So you draw the tube, and everybody agrees what you're doing, and both RNs initial, sign, and send that tube down. And then the lab goes through and they figure out the blood group, blood type, all the factors. And you'll hear it referred to, do they have a clot on hand? Because it's clotted at that point. It's only good for 72 hours. So at 72 and a half hours, if you need to order another transfusion for the patient, you have to repeat the procedure. Yes, they haven't left the hospital. No, their blood type hasn't changed. They've been here the whole time. You draw another tube, another nurse initials it, send it down to the lab, and then eventually they release that next unit. This is the one place where, even with the electronic records, you'll find it's still paper-based. You will enter the information into the computer, but the consent and the initial data is recorded on a transfusion sheet. Do you have to get a consent first? Yeah, Dick, you had a question?
I was just wondering, do you know why it's only valid for 72 hours?
I'm going to say that empirically there were problems, so all I can think of is that somewhere along the way, years and years ago, they had incidents where patients were being injured somehow. I honestly don't know the history on that. It's just one of those protocols that's been around forever, yeah. Oh, maybe okay, so I can see that. Because we only test for certain factors, right? So maybe one of those other more subtle factors is now activated, and you need to use different blood than you did before, one that doesn't trigger another transfusion reaction, or that could. I mean, that makes the most sense. Thank you. I appreciate that. That's a good idea. I mean, a good explanation. You did some of the reading anyway. I'm going to be harping on you guys to do the reading, because otherwise you will not pass the NCLEX. Not that really, well, it does matter to me, but, you know, who wants to get through school, owe $100,000, and not have a job? Not a plan. And that's the potential reality, you know, not to make you stressed or anything. Okay. So, before, you know, that was, yeah, do you need to get a consent? Are there situations where you don't need to get a consent? Only if it's, it's emergent, they're in the ED kind of thing, there's no family, nobody to ask, you don't know if they're a Jehovah's Witness.
So, in case of Jehovah's Witness, do we not do the transfusion at all?
It's up to the patient. So, yeah, you know, if somebody refuses treatment, they get to do so. Now, last year at Sutter, there was a patient there, Jehovah's Witness. She insisted that she did not want blood, and she had a procedure where she lost like a lot. And she came out of surgery, and the doctor met with her, said, "You're probably going to die if we don't give you blood." And she said, "No, I don't want blood." Her daughter overrode her decision, and they gave her blood. The only rationale I can come up with for them doing what they did was that because she was so anemic in that moment, that they could make the argument that she was not mentally competent to answer the question. And therefore, they could ask a family member. Because otherwise, what they did was profoundly wrong. They violated her wishes if she was actually competent. Now, later, she didn't complain about it. She was actually apparently glad to still be alive. I don't know how the relationship with her and her daughter is going, but at least she's around to have a relationship to argue with her daughter about why she did that. But typically, you would say no. You wouldn't give them blood or blood products, because that's their religious belief, yeah.
Was she like the power of attorney or something, or were they just saying that she wasn't?
They didn't, in reading the notes, they didn't actually say. The only thing I can say is that had she later filed a complaint, I can hear the doctor saying, well, she wasn't mentally competent. So if somebody is, if they've been you loaded them up with drugs, of course, she was just out of surgery, they don't get, that's why you get consents before you give them any sedatives. Because they're not, once you give them the drugs, pre-surgery, they're no longer competent to answer. So you always ask before. Okay. I think that covers consent. So the things that we test for, of course, AB compatibility, ABO, RH. They screen the donor's blood for HIV, syphilis, West Nile virus, and other specific antigens that could cause a reaction. And the same thing, the recipient's blood is screened for existing antibodies. So antibodies are what we make in response to antigens which come from the outside. Don't get those two confused. That will be on quizzes and tests. And you want to make sure you know the definition of each, which one does what. Okay? Antigens are the bad things. Antibodies are the cavalry. And tape, you don't see it much anymore. They used to, mix the two the two drops of blood together to see if they agglutinated. So, a couple of minutes later, if you've got all these clumps in there, you know that they're incompatible. But that's a pretty major thing. How often can you give blood as a donor? Very good. 2 months, yeah, every 8 weeks. If you're 3 foot tall and 100 pounds, you can't give blood. It's not about your height, it's about your weight. You have to be 110 pounds minimum. I've passed that a couple times, so I'm good. But based on all the drugs I take, they won't take my blood. Although I have been a plasma donor for plasmapheresis. Anyway. You can't do your autologous blood transfusion for yourself in under 72 hours prior to surgery. And you can be a designated donor for a family member, of course, assuming you're compatible. Depends on whether or not you like your brother-in-law. Like I said, whole blood, almost never used. So basically, whole blood only gives you 200 mLs of RBCs in a 500 mLs. And so the reason for packed red cells is you want to give the red cells. You don't want to give the fluid. In fact, it's very common. Okay, I'm going to ask you, and we'll see if you did any other reading. PRBCs. Typically, it's 300 mLs, more or less. They can vary. There's some plasma. You can expect a rise in the hematocrit of 3% per unit. You might want to remember that. That's a good test question. And it's got preservatives to maintain anticoagulation and proper pH and stuff. Old blood, like when it's getting near its expiration date, it's better if you can get new blood. But if you're in that situation, you'll probably take any blood you can get. Yeah.
How long does blood last from the time it's donated to?
I don't remember if it's 30 or 60 days. It's actually frozen. So it has to be thawed out and stuff like that. But yes, it definitely has a shelf life. And that's why I'm saying old blood is it actually, what it loses is its oxygen carrying capacity. That's what drops off most dramatically. Where am I here? I'm on 11. So what are we talking about? And your hemoglobin is going to be raised by 1 milligram per. Does it have hemoglobin in there, or it just talks about hematocrit? So you want to know both. One is you'll go up 1 gram, so your hemoglobin will go from like 12 to 13. Your hematocrit will go from 33 to 36.
1 milligram, is that?
Yeah. Yeah. So frequently, and this particularly with our patients that are CHF patients, not only will they get the blood, but it'll be followed by Lasix. Why do you think? Okay. So they can't, CHF patients have real challenges with extra fluid. You don't need the fluid, you need the red cells and the plasma perhaps. So you give them Lasix, so they pee out the fluid, so you're not challenging the heart. What might you find yourself giving somebody prophylactically? So what's prophylaxis mean? Preventative. So that means you're probably going to give it before they get the transfusion. What can you imagine them getting prior to a transfusion? Because none of you probably have participated in a transfusion yet, right, in the hospital? You went to get it, but were you there while they actually talked about what they were going to do and how they did it? Okay. That's the more fun part. So what is a common sort of reaction to blood, even if it's not a severe hemolytic reaction? What do people often experience? Oh God, let's hope not. That would be severe. I'm thinking more along the inflammatory response side of things. What's a common inflammatory response that we all get? Usually it's like the first sign that you've got something going wrong, like an infection or whatever. Fever. So what would you give somebody for fever in the hospital? Probably. Okay, what medication would that be? Probably not an NSAID. Actually, they don't like to give NSAIDs in the hospital because of all the side effects, the bleeding, and everything that goes with that. Because NSAIDs will enhance bleeding. They're aspirin, ibuprofen. They are antipyretic, but there's other antipyretics that don't have those effects. Yeah. There you go. Tylenol. Yes, acetaminophen. That'll be the typical order. Is they'll get some acetaminophen. NSAIDs. They really, because of surgeries and everything else and the propensity for, bleeding. That's why you don't take NSAIDs with Coumadin, because it lowers your INR even, it makes your INR higher, or you clot. It takes longer to clot. Okay, so we mentioned the thought that this was an inflammatory response. What's another thing you can give somebody to help sort of mitigate that inflammatory response? That would be steroids are kind of right, but they're very potent drugs. We try not to give those. Benadryl, yeah. Otherwise known as diphenhydramine. So they'll often have an order for, prior to the transfusion, give them diphenhydramine and acetaminophen, because that minimizes the discomfort. Now, if they start experiencing back pain and chest pain and stuff like that, stop the transfusion. They're probably having a reaction, or at least you want to find out if they're having a reaction. So this is when you have a question about what size needle, what size IV do I place? Of course, last week we talked about, in essence, the smallest you can get away with, because it causes the least discomfort. Now, here's one of the things you get to do in nursing. It's like you have contradictory priorities. You should be placing the smallest possible IV. What if they might need blood? What do you want to do? You want to go with the smallest possible IV? You want to put that 24 in? Why don't you want a 24? Yeah, when the catheter gets too small, it can damage the red cells. Also, just, let me tell you, if you're trying to push, if you're trying to do a bolus of 250 an hour through a 24 gauge needle, it ain't going to work. It's not good. So 18 to 20 gauge. Have any of you seen an 18 gauge IV yet? You have? So it had an 18? Have you seen them? Well, they'll come back from surgery sometimes with 16s. I've even seen a 14. It's like, that's a tunnel. It's like, big old, it's like, please don't stick that thing in me. Okay. Your typical transfusion times are between 1.5 and 4 hours. You do not want to exceed 4 hours per unit. Once it's at room temperature and you're transfusing, is blood a good bacterial medium? Yeah, it's way better than TPN. Bacteria just love this stuff. So maximum time to transfuse is 4 hours. This 1.5 hours, that's kind of, in general. If they're bleeding out, that's a whole different story. I've seen, well, you haven't, have you seen pressure bags? You haven't been in the ICU and stuff yet. Good music next door. Pressure bags are used in the ICU and the CCICU, CVICU, ED. When they have, a lot of times if they have an art line of stuff, they actually crank it up to like 220 millimeters of mercury. And it's NS that's going through this really tiny catheter to prevent the line from clotting. But if you put that 220 millimeters of mercury on a bag of blood, it's going to push it right through. So I've seen people standing there holding a bag, forcing it, because this is somebody who's bleeding out, their volume depleted, they're not going to make it. you don't worry about that hour and a half. You're going to get it into as fast as you can. Somebody that maybe had a cardiac cath and the site has hemorrhaged, and they now have a hematoma the size of a basketball. It can happen. So all their blood is no longer in their body. It's in that hematoma. You're going to give them blood as fast as you can. But that's the exception. 170 to 260 micron filter. What's the filter for? Why are we filtering the blood? What do you not want to be introducing into the bloodstream? Not clots. What else? Bacteria. Good. Okay. Of course, ABO compatibility, PRBCs are usually leukodepleted. What does that mean? They don't have a lot of white cells, yeah. And they may have been irradiated. So if you have somebody who is immune compromised, you may give them irradiated blood. And that's, again, to reduce any further reduce any chance of some kind of a bloodborne infection, as well as the lymphocytes and stuff like that participate. When you give blood, the blood that's coming to you also has antibodies against things in your system. So you can get a transfusion reaction from the blood that's coming, not your own blood. This is particularly true with, like HIV patients and stuff. So they'll use irradiated blood to reduce that. Right? Okay, you're just scratching your head. You use Y tubing to hang blood, and, it'll be like a 250 bag or even a 100 for the NS. So, what you do is you prime the whole system with saline. And once that's in, you clamp that off, and then you open this side and prime the rest of the system with the blood, and then you run that through. What happens when that unit is done? Do you run all the saline in after they've finished their blood transfusion? Do you have an order to give 150, 200 mLs of saline? No, it's just there to flush the line and prime it. So you do not finish running the saline. If they're going to get a second unit, do you have to get a whole new setup? Or can you spike a second unit and run the same setup if it's under 4 hours that is the last one is running, or 4 hours or less? In other words, can you run 2 units through the same setup? Yeah. But that's it, because then you're at 8 hours and your blood tubing is only good for 8 hours. So if they're going to get a third unit, you have to get another setup and start all over again. Platelets. So sometimes we only get platelets. What line am I on here? 14. Was there a question there? Not yet. So what do platelets do physiologically? Why do we have them? Clotting, yeah. So if somebody has got dyscrasia, they've got a bleeding problem, you may just give platelets. There is a condition called HIT, which you probably have not read about yet. So I'll tell you what it is. It's heparin-induced thrombocytopenia. So what is thrombocytopenia? Small amount of thrombocytes. What are thrombocytes? Platelets! Yeah, it confuses people. It's like thrombocytopenia means you don't have enough platelets. If you don't have enough platelets, you can't clot. People that have been sent, some people are allergic to heparin. They have a heparin allergy. And if they've been sensitized, like they were in the hospital 2 weeks ago and they were giving them, the sub-Q heparin, and then they come back and they're going to have a procedure, and they need lots of heparin, they can have an allergic reaction that basically leads to, in essence, this dyscrasia of massive clotting throughout the system. I had a patient, it was a very tragic experience, actually. He was 55. He was the sole provider, sole caregiver for his invalid wife, had a son in college who was about 20. And he came in for chest pain. They took him to the cath lab and said, you actually need bypass surgery. So they sent him back to the floor on a heparin drip because they just kind of wanted to keep things open until they could get him into the surgical suite. About 6 hours into it, he tells the nurse, he says, I'm losing I can't feel anything in my left leg. And they figured out that he had a thrombus running down the entire femoral artery because he was having this severe reaction. So they took him to surgery. They tried to embolize, which means they tried to remove the clot that was in the femoral artery. They couldn't. So they did a guillotine amputation of his left mid-thigh. So a guillotine means they don't have a flap or anything. They just chop straight through. Now, luckily, this guy, well, luckily for him, in a way, he never actually regained consciousness. Because what's happening is he's showering clots everywhere. He's having strokes. If you look up HIT, if you Google HIT, you'll see black fingers, black toes, all these appendages. It's horrible. He ultimately passed away. Took about 3 weeks. And it was, really depressing to take care of. It was hard. And that's one of the things about our job that at times is hard. You really get involved in things like this. But your job as a nurse is you're watching that patient's labs every day, and you see their platelets are dropping, and they're getting sub-Q heparin. You call the doctor and say, look, I think he's experiencing thrombocytopenia. He's reacting to the heparin, and his thrombocytes are dropping off. So let's fix that. They might put him on Lovenox. They might pick something else. What's Lovenox? How's Lovenox different than heparin? Is Lovenox a kind of heparin? Yeah, it is. It's low molecular weight heparin. So they've chopped part of the molecule off. It tends to be less allergenic. But you have to, you send people home on it, and they have to start injecting themselves. They love it. Let me tell you, I've done it. It's like, I know this really won't hurt that much, and then it burns for the next 10 minutes. By the way, heparin doesn't hurt when you give it, but for about the next 5 minutes, they will have discomfort. And tell them, you're going to feel a little burning, itching sensation for a few minutes. It will go away. So if their platelet count is less than 10K, you're going to give a unit or 2 or 3 of platelets. FFP. Freezed. I didn't write all of these, please. The word freeze does not actually exist. That must have been, God knows, probably an autocorrect that was deranged. Frozen within 8 hours of collection. It's the liquid portion of the blood. It's the plasma, yeah.
Sorry to back a little bit. Does Lovenox also come to where you shake?
Yeah. At least based on my personal experience. Yes. It's like, do I have to do this again? And this is used to replace your plasma proteins. Has all kinds of clotting factors and good stuff in it. Albumin. There's no allergenic issues, so it doesn't have to be screened. And we all know what albumin does, right? What's it do with the bloodstream? What's it say? So it's going to pull fluid. Who's going to get albumin? What patient is typically going to get albumin? Yeah, maybe. Okay, and liver failure is the patient who gets albumin. Because, yes, their albumin is minuscule, it's very low, they're edematous everywhere, they have ascites, all that good stuff. A hemolytic reaction, bad karma. Basically, the allergen comes in, and the antibodies go in, and they chew it all up, and there's all this debris in the bloodstream, and it's bad. Acute hemolytic, you stop the transfusion. You hang saline. You're going to be doing frequent vitals, and I mean like maybe every 5 minutes, because they're actually going to go to the ICU. Yes, you contact the provider. This is the time you call the doctor, but you're not calling the doctor without something to say. You're saying, hey, they're having a transfusion reaction. Let's fix this. They're going to get dopamine, diet. Why might they give what's dopamine do? Yeah, it acts on the heart. It's an inotrope, which means it increases the strength of contraction. Diuretics, because you're trying to get stuff back out. Call the blood bank. We had a transfusion reaction. And you collect the blood and urine samples. They'll be used for later analysis. A febrile reaction is common. 1 degree centigrade. Now, if it's 2 or 3 degrees, you got problems because that's abnormal. What's it? What time is it? Okay, I'm good. Surgical patients come back. Have you read post-op orders about fever, when to call the doctor? Have any of you seen those yet? I see a nod, so tell me what you saw.
I remember reading after some of the patients on the nurses were that they had certain, like some doctors would say that it was like within 4 hours.
Yeah, usually where I was going with this is if their temperature is under 101, that's actually a normal reaction, inflammatory reaction to the surgery. So if you call the surgeon and they've got a temp of, 90, 100, 100.5, they're going to be like, why are you calling me? That's expected. And you're not going to give them NSAIDs because it'll make them bleed. Might give them acetaminophen. There's usually an order that goes with that. But you only call the doctor if it's over whatever their parameter is, their threshold. And the fever is just due to the antibody production. It is part of the inflammatory response. They may have fever, chills, headache, nausea, vomiting, and hypotension. Mild allergic reaction. Oh, now you're starting to get into hives and stuff, and maybe little pustules. Well, those aren't pustules. They're having a senior moment. Okay. It'll come to me like at 2 a.m. Okay. Allergic reaction. Again, you disconnect the blood, you run saline, frequent vitals, notify the provider, and anticipate orders for antihistamines, epinephrine, and steroids. Why the steroids? Somebody used that as an example earlier. Why are you going to give them steroids? To suppress the immune response, yeah. That's also the risk with steroids. If you give somebody steroids and they have an infection, then you can get a runaway infection because you've suppressed the immune response. Particularly if somebody has like an eye infection or something, you don't want to give them steroids without knowing what you're doing because they could lose their eyesight. Graft versus host disease. Remember I mentioned that sometimes you get the transfusion and the antibodies that are in the transfusion react and take over. Again, this will be like an HIV patient. They're immune compromised to begin with, and it turns out that the antibodies in the transfusion are more potent than their own immune system. Circulatory overload. What's that? What do we call that? Fluid overload. So if it's a CHF patient, the heart's having to work too hard because they've got a lot more blood, a lot more fluid, really. Hyperkalemia. Why would they get hyperkalemic? Nobody knows? No. Any of you? Okay, Nick, you? Yeah. I appreciate your thought process, but we're heading down the wrong track, and I'm not helping you out here. Have any of you had a chance to draw blood on a patient yet? No, the lab always does it. Okay. So, you can draw blood from an IV. You have to stop it. But remember we were talking about the size of the lumen? So if you're drawn from their IV, which patients appreciate because they're not sticking them, they already have the IV in place, and the lumen is small, and you're pulling really hard to get that 10 mLs, and then you put it into the tube for the lab, you send it down, you'll get a call back from the lab for a critical value on potassium. Because what happens when you're doing that is you damage the red cells. When the red cells get damaged, they release potassium. So you get a high potassium level in that blood draw. The longer that blood sits in the blood bank, as the cells deteriorate over time, they release potassium. So when you're giving them blood, you may be giving them excess potassium as well. It's always good to know this physiology stuff. It's handy. And of course, disease transmission. We've talked about a lot of those. So what are the rules you need to follow? Let's talk about Dorothy again. Where am I confused? We talked about, so if you go back and look at the notes on slide 22, you'll see there's like another 2 pages of rules to follow for safety. I will leave that as an exercise to the student to read those. I'm not going to read you 2 pages of rules to follow. I have better things to do with my time, and you have better things to do with your time. So let's go back to she is much better now. She has 3 days post-op. Her H&H is 12 and 35, which is not wonderful, but it's okay. She's ambulating with a walker and preparing for discharge. How soon do they get people up after a total knee? Next day. That's the goal. Next day. Same thing with total hip. One of the things I urge you to check out, even though you're probably not going to be in a critical care unit at this point, but you can ask on the unit that you're on. So, at this hospital, what's the criteria for a transfusion? Now, you can find, like at the Kaiser facilities, they're actually fairly standardized. The private facilities, it'll be kind of up to the doctor. But you'll find that the numbers that you hear will be different than what you're reading in the book, probably. So that's actually something when you're working, is you want to know on that unit what's considered the threshold for them needing a transfusion. In the intensive care, the numbers are going to be wildly different than anything you've ever seen before they will give a transfusion. And if you're in a cardiovascular intensive care, they'll blow your mind with the numbers they tell you. Oh, yeah, when they're down to 8 and 20, we'll give them a transfusion. And part of the reason for that is you do run into situations because of fluids that are being given and everything else. You get into this. I think I mentioned last week about somebody, you're looking at their H&H and somebody says, oh, that's dilutional. It's because you've given them so much fluids that you've diluted their blood. You will probably all do this once and probably only once. You'll have a patient and you need to draw blood and it's in a hurry and lots of things are going and you're not paying attention and they've got an IV running at 250 an hour and you draw from the same arm and then you get the call from the lab saying the patient is dying, could you please do something about it, because they don't have any blood, because all you drew was saline from their IV. Like I said, you'll only do it once, but most of us do it once. It's like, oh, God, I just lost track of it. Or if they've got something with sugar running in it, they come back with a blood sugar of 700. Yeah. Questions? Because we're actually I think we're sort of done with the lecture, right? Yeah. Review the rules on your notes page. See? It was even in the lecture. Questions? Ask away. No, and actually one of my clinical instructors is like, when is skills day? So I really need to talk with Dr. Fink. I know there are emails in my inbox talking about the planning, and I hate to admit it, I have been so overwhelmed with just trying to get caught up that I haven't paid close attention other than say, yeah, sounds good. So I will look more closely and get you guys information on that. I will see if I can fix the Google Docs. What do you want to know about next week for your first test, other than we know how many questions, how many points? Yeah. I would think it would be a good idea to know the important lab values. You should know your chemistries, and you want to know like your H and H stuff. That would be handy to know. Know what's a high or a... By the way, if somebody says their potassium is high, my first question is going to be, how high? Have any of you had a patient that had a BNP yet? Blood natriuretic peptide? So it's a diagnostic really for CHF. Under like 400 is kind of normal. I'm telling a story. Hang on a second for a minute. Hang on a minute, Min. Sorry about that. If you tell me that they have a high BNP, what number am I going to think? 1,000? Okay. I've had a patient with a BNP of 29,000. So if you say hi to me with no number, I'm thinking 29,000. And maybe it is only 1,000. So the way you want to report things like that, their BNP is elevated at 1,000. Their potassium is low at 3. Always include the number, because that other one, the subjective one, could be in that other person's brain some wild, crazy number. You had a question. I saw an arm go up over here.
I was just wondering, like, which ones you would consider the most important, because there's so many lab values out there.
Okay, here's the lab values that I always look at. I look at their CBC. I want to know what their white count is. Looking at electrolytes, in particular, I look at potassium, calcium less so. You may want to pay attention to their CO2. I always look at creatinine. And if it's available, I look at albumin. With those, I have an idea of what's going on with this patient. Those are all kind of, at some level to me, things that can be critically important to their welfare. If their albumin's low, I'm going to not be surprised if I walk in the room and see somebody who's a demesis. If their creatinine is elevated, I suspect that they're either a dialysis patient, if not stated already, or they're going into renal failure. If their CO2 is elevated, they're not breathing well, perhaps. They're not doing a gas exchange. If their white count is elevated, I hopefully will have previous days to see if it's going up or down. Did I ask this group, or was it my clinical that I said, do you call the doctor for a white count of 18,000? Well, okay, that's it. So normal's like 12, over 12 is considered elevated. If the day before it was 22 and it's coming down, the doctor is going to be like, why are you calling me? If the day before it was 12 and it's 22 today, damn right I'm calling, excuse me. Yes, I'm calling the doctor. Because that indicates something very bad is going on, potentially bad. It's a good question, yeah. And those are the kinds of questions that will probably show up on a exam. Things about, determining, is this a good value, or should I be doing something about it? Other questions? We have a couple minutes yet, unless you all really want to run out real fast, which you're welcome to do too, I guess. I'm actually done with my lecture. But I'm happy to answer questions. Min, you had a question.
How many minutes do you gain?
It's a 70-minute exam. Hour and 10 minutes. Except for those that are, have dispensation and they're elsewhere. They get more time. Quietly walk out and hold a conversation outdoor with the coffee pot. And then once everybody is done, you come back. And then I'm getting to you, Nick. Typically what we do is form into groups of like 5, and you take the test again as a group. And I walk around and sort of answer questions, and then you get a grade for the group, and that grade sort of works out as extra credit. Cool, yeah, it's extra credit. We love extra credit. Okay, Nick, you had a question?
So that was kind of my question. I was just wondering, lecture
There won't be any really, well, there'll be a lecture after. Am I doing a lecture? No, not really. It will take the whole class to do the test and the review. Yeah. I had a senior moment there when I said lecture. But in essence, I'll be walking around a room, and you guys will be saying, "Yeah, no, it's this," and I'll say, "Bob, come here. Which one is it?" And I'll say, "Well, let's talk about that." Typically, I won't just say the answer because that's useless. You need to kind of come to your own conclusions. You look like you have a question. No, you know it all. You're ready. You're going to get 100. I want you guys to do well on this exam. I really do. Please do the reading. It will make it a lot easier to do the exam. Read the notes. Take a look at those questions that say, by the end of this, you should know how to answer this. Those really are your study. Don't ask me for a study guide. That is the study guide. It's telling you what you need to know by the end of it. Yeah, Min.
For the reading, do you want to read the fundamentals and Potter?
Well, it turns out that Perry and Potter, I have a different edition than you guys. So the page numbers are a little off. But if you look at the topic, you can look at Perry and Potter and find the right topic. Perry and Potter, regardless of which book it is about how to do things, physical skills as a nurse, how to set up, do it, and be done with it, and what you need to be looking for. No, the focus is really on the text, the primary text. Nursing concepts, we're talking about that all the time. When I'm talking about priorities, those are concepts. I just use a different word. What are your concerns? And that's going to be really the essence of the essay question is, when you walk into that room, what are you worried about? And like I said, I don't want to hear falls. I don't want to hear pain. I don't want to hear safety, and I don't want to hear call the doctor. I want to hear, oh, he's a CHF patient, and I'm worried about oxygen, gas exchange, fluid overload, the heart function, and figure out. Somehow people seem to have lost what the word priority actually means. If I say, give me your priorities, give me your first two priorities, that means that number one is more important than number two. Well, by the way, I will ask you to tell me why your number one is more important than number two. Why did you put that one first? You don't get to just say, oh, first priority is this and second priority is that. You're going to have to tell me why you put them in that order. That'll probably be the toughest question of all. Why do you think this one's more important than that? But if you think about Bob's mantra of what's going to kill my patient first, it will help you answer that question. Other questions? I know, it's humorous. You'll get so tired of that. By the end of the semester, you'll be able to say it before I do. But of the nurses I talk to on the floor, when I say that that's my approach, it's like, oh yeah, I know. It really is the way the better nurses work. What is going to go wrong? And what's my plan to deal with it? Because if you've thought about it, you are much better prepared to actually act. If it comes as a surprise, hey, in the hospital, surprises are bad. We don't like surprises. So try and do everything you can to avoid them. Like, where'd that baby go? Well, you're not doing OB now, so you don't have to worry about it. Okay, see you next. When? Well, I'll see you. No, I won't see any of you on Monday because we have a day off. So I'll just see you next Wednesday. Have a great week. Email me all kinds of questions. I do answer them, I think.